And I'll just talk about some different fee structures and some reasoning behind, maybe why or why not you want to consider what you're doing. Is first of all, when you look at the consultation, there's um, the degrees of the consultation and the in-depthness of a consultation. So when we look at the consultation examination, really there's 5 different categories, right, of examination. Now, most of the time, a chiropractic office visit fits into the 3rd highest level of an examination. Are any of you guys billing the 4th or 5th level of an examination?
We typically look the fourth PI case.
Okay.
If they're MRI results or something like that, or they've already been to the neurologist, PID.
Okay, I just need you to be aware of a couple things. Is you do know that each level of an examination, there's certain criteria of work that you have to have documented. Okay, so there has to be so many bullets covered in each of these categories. So essentially, the more categories you have and the more bullets, the more it moves up. And if you do not have that covered, that's when you're going to start getting into insurance fraud, especially when it looks like it's a system or a scheme. Remember, one of the key words in fraud is a scheme, not an incidental happening, a scheme. Now, I'll tell you what else is a scheme. If they pull your records, David, and you're doing category 4 examinations and they're all on personal injury and none of them are on cash, that's a scheme. Do you understand what I just said?
Yep.
So be highly aware of what you're doing here. And just gearing everything toward, a higher paying patient with personal injury versus cash. Be highly aware of what you're doing when you're doing this. Now, I know this from personal experience because when they subpoenaed my records, they actually had doctors come in and testify that all the recommendations, and the word they used was all. We all were recommended, all the patients were recommended 20 or 30 visits. And I was sitting there going, that's not right. I know better than that. And it reminded me of a case with Abraham Lincoln, that he won a case. It was a murder case that he took, and every witness came up there saying that the guy killed the person. All of them testified that it was on a full moon. And he went back into the archives and showed that it was not a full moon. And the point being is, everybody testified to this one fact, and when he showed that one fact was false, it totally discredited all of their information relative to the murder, is what it did, and he got that guy off. And so when I was dealing with the federal government and they were trying to levy personal or fraud allegations, they actually had doctors come up and say that every client was told to be offered 30 or 40 visits. Now, this was right in the middle of the trial, and I knew that that was wrong. So what I did is that night, right after the trial, I went up into the evidence room and I looked at the box. I just pulled one of the boxes of files, and I ran a statistical analysis on each category of patient: cash, major medical, personal injury, work comp, and Medicare. And I put in there if they were or were not offered a treatment plan, and then what treatment plan they were offered. And so they had every witness come in saying, all of them, all witnesses said that we were told to recommend 20 or 30 visits. And they said all. And they said, and so all of them kept coming in. Well, I show up the next day with the statistics, and the statistics were spread out. In other words, there were cash patients that were offered prepays. There were ones that weren't. There were ones that were offered 20, some were offered 30. There were major medical patients that weren't offered 20 or 30 visits at all. and then there were some that were offered 20 and some. So it showed this whole variation. And because they were absolutist about it, I was able to go in there and go, no, statistically, everything everybody just testified to, they all just lied on stage. Here's the stats and there's the folders to prove it. And right then, it shifted everything because we were talking from facts as opposed to emotion. Now, this is very true. This is what will happen. And so we want to be aware of what to bill and how to bill and all that. But what are some of the major traps? Well, one of the major traps is if you're showing a scheme. In other words, the high insurance paying person gets all the full x-rays, the top of the line examination, and 2 or 3 therapies. And the cash patient comes in and typically gets, the adjustment and no therapies, or maybe no x-rays or 1 or 2 x-rays. See, when that happens incidentally, it's no big deal. But when it shows a pattern, you're showing a scheme, and schemes are shown to defraud. You're showing a scheme to go after more money is what's happening. So you need to be aware of fraud and the definitions of fraud. Well, that's one of the definitions of fraud, is a scheme, okay? A pattern, okay? Now, having said that, when you bill the examination, remember all of these categories, and this is a major problem with chiropractic, is they'll bill for a category, whether it's an exam or therapy or whatever, and they don't have the proper documentation for that particular injury or that particular diagnosis. And I'll give you a couple examples here. So if you're going to do a level 4 exam, a level 5 exam is really almost a specialist person. That's almost, if you're dead, is a level 5 exam. A level 4 exam commonly can be a personal injury. But all I'm saying is, number one, I hope you're aware that you have to do more to fill those categories for the diagnostic code of a level 4 exam. So I hope you're aware of that. You're aware of that, right, David?
Yes. Yes.
Okay, so you can't just do the exact same thing for level 3 as you do a level 4 and then just bill for level 4. So number one, make sure you're filling that. Now, the other issue is that people do also is, with each diagnosis, you have to have your own separate notes. So if it's a neck diagnosis, back notes, all of those have their own diagnoses, and they have their own workup, range of motion, orthopedic test, and all that. Well, they also have their own SOAP notes. And the reason I'm telling you this is another common problem that doctors will, I'll give you an example, a real common example is doctors will bill for maybe extremities. So they'll bill for the main area, and then they'll bill for an extremity area, and they will not have notes in the diagnostics or the supportive care for the extremity area. That's a very common form of malfeasance. So just be aware that if you're going to be billing for additional injured areas, just be aware you do need to make sure you have the consultation exam for that area, the diagnosis for that area, as well as the supporting notes for that area. So typically a chiropractic exam is a category 3 when it's workers' compensation or personal injury. It can easily be justified as a category 4 just because of the extra work that you do need to do. Make sure you're doing that work. And then same with the exam. Some people will bill in extra exams, if you're going to do the exam for an elbow or the knee or other factors. And then also some people get into itemizing billing. And that's another thing. I don't know if any of you guys are doing cluster billing, diagnostic billing, where you actually bill separately for each test, like for the range of motion, bill for the muscle test, bill for nerve testing and all that. Okay. So just be aware that that is not how they're supposed to be billed also, separated out. And that's seen as a scheme also from a billing perspective for more money. So just be aware of the billing aspect of that as opposed to clustering them all together, calling it the exam, maybe a category 3 exam and billing for that exam. So that's a common issue. One point that I want to point out is some doctors will kind of get off track. And, you know, they'll, with the back pain or neck pain or whatever, and the consultation, exam, and therapy, and they'll start doing incidental things. Here's an incidental thing. Home instructions. You guys know you can bill for home instructions, right? Okay. So you can bill for home instructions. You can bill for like home instructions with therapies or exercise, things like that. Or you can bill ancillary for, like I said, with any extremities. And so sometimes you'll have doctors that'll bill not only the high code, but then also go vertical, horizontal, and they're billing for home instructions. They're billing for, you know, a traction unit at home, a TENS unit. They're billing for orthotics, and they're billing for, in other words, all this horizontal billing. And I just want to share with you a line of thought on that. Is I never did that, and I'll just tell you why, and I don't know if this will make sense to you, is generally when doctors aren't good at getting new business and keeping it, then they start improvising, you know, really creative billing methods. The problem, there's two problems with that. Is one is you have to have all this documented, and that becomes the first problem because, as you know, we get pretty lazy in documenting, but we don't get lazy in billing. So it gets pretty easy to write the bill down but not document it. And that leads to problems. So you just need to be aware of that. But from a business standpoint, you've got to look at your business as a factory line. And not that patients are inanimate objects. That's not what I mean at all. But the point is, the more variations that you do in a business, the less efficiencies and volume you'll be able to do in the business. And typically your overhead goes up also. I'll give you an example. If you just did the consultation, examination, modified 3, spinal therapy, and when they came through, let's say you did one treatment and one passive treatment and one modified active. It's absolutely crystal clear what they're getting, how they're getting it, when they're getting it, with all 3 major components of overhead. Space, it's real clear. Labor, it's real clear as far as trained, who you need and how they're trained in and what to say. And equipment, what equipment you need. And so the more narrow you are, the higher efficiencies you'll have. You'll be able to do more volume with less overhead and have higher profit margin. Now here's the problem that so many doctors have. They don't know how to get business. They don't know how to maximize their efficiencies. So instead of knowing the basics of advertising and educational sales to get and keep business, now they get creative in their billing. And not only in their billing, but now they get creative in all their different. So now you have an office that's doing treatments. Now they're doing acupuncture. Now they're doing ibuprofens. Now they're doing nutritional this. Now they're doing orthotics. In other words, they keep line extending. And what most people don't realize is the more you line extend, the slower your machine is going to be. Let me be real clear on this because most people just don't understand this. The more you line extend, in other words, now I've got to have modified space to some degree. My systems through the office change. If I'm going to be doing acupuncture, what I say and where the patient goes changes. If I'm going to be doing orthotics, what I say and how I change. In other words, one or two little things maybe doesn't get to be that big of a deal. But as you keep adding on, and chiropractors are terrible at this because they don't know how to maximize their time for money. The next thing you do, they're chasing everything horizontally. So now they got really bad systems for flow. So they can't see a whole lot because of the flow problem. Now they have more overhead because they have to buy other types of equipment, whether it's a spinal decompression table. By the way, this is why I never did all this other stuff in chiropractic, because I knew it would slow me down from having one highly profitable, highly efficient machine. I knew that my labor would change, my patient flow would change, everything would, my overhead would change. But the three major components that changes, your space changes, your labor changes, not only who you possibly need, but what they're instructed to do. It's a lot easier to have 3 systems trained in than say 20 systems trained in. And then same with equipment. Now you don't have all these extra costs with all these variables in equipment. So it's very streamlined. But typically that only happens with the chiropractors that know how to get and keep business. So that's when you will maximize your time for energy and actually maximize your profit margin. So the more you keep adding on horizontally, whether it's spinal decompression, massage, orthotics, detox, all this other stuff, nutrition, all these horizontal factors, just be aware all of them are affecting the top. They're all affecting your profit margin for the lower, not the better. Now, here's the bad side from a marketing standpoint. If you don't know sales and advertising enough to get one category of business, back pain, neck pain, and move it through, you won't know advertising and sales to get any of these other businesses and maximize their time for money either. And that's what most chiropractors just don't understand. So they don't know how to do it here, so they rush over here thinking, I'll just get some more business over here. And they do get what's called market forces. So now they've line extended with their labor, space, their equipment, their internal training, where, as far as the patient, where's the patient flow go, whether it's acupuncture, whether it's orthotics, whether it's spinal decompression, whether it's nutrition. I mean, you can look at chiropractic and they do everything. And so next thing you know, everything is so spread out that it's affecting space, labor, and equipment, which decreases your profit margin. But also what it does is the chiropractor who does that doesn't know advertising or educational sales with patient acquisition or retention in the first place. And that's typically why he's going horizontal to try to fill his time for money. And typically he doesn't even know advertising or sales, because if he did, he never would have had to go vertical in the first place. Let me say what I just said because how important it is. When you know it and you have the knowledge and skill, you'll be able to maximize your time for money in that category. When you don't, that's typically when you start looking in all these other directions. It decreases your profit margin, increases your overhead, increases your workloads and efficiencies with space, labor, and equipment. And you won't have the knowledge, typically you won't have the knowledge there to maximize your time for money in any one of those categories, because like I said, if you did, you never would have left into that category. You would have stayed in your category and maximized your time for money. So that's why I never got caught up in, remember what I always said? I said, if you can't do it for X amount of visits, and I said in my mind it was 200 visits a week, exchanging your time for money. I said, if you can't do it for that, then don't pick it up at all. It doesn't matter if it's for one patient or two, because now that 1 or 2 patients has slowed down my whole machine, and it's affected me in all these other ways that I'm never going to be able to maximize my machine. And so those are some of the core concepts relative to doing the line extension. And next thing you know, you're not just doing chiropractic, you're doing orthotics, you're doing spinal decompression, you're doing acupuncture. And now you just have market forces in any of them. None of them are being maximized. And now you've added more space, labor, and equipment. Your profit margin is shrunk, as well as your headaches. You got a lot more headaches now. So those are some of the major factors you're going to want to consider. And so most people will actually go to it by default. They don't even realize what I just said. They just, by default, they don't know how to get any more business in the vertical category. And so that by default, they start chasing horizontal categories. It's not because of a business sense. It's really from weakness. It's not strength. So last is if you plan on replicating your business, the further you line extend, the harder it's going to be to replicate it. So the more variables you put in horizontally in all your fee structures, orthotics, acupuncture, spinal decompression, nutrition, detox, whatever, you're going to have that much more hard of a time replicating all of those systems and have a less likelihood, as opposed to back pain, neck pain, maximize your time for money, high efficiencies, low space, labor, and equipment, high profit margin. That's a very replicatable system. So be aware of the last factor is replication. So if you don't care about replication, then that's a factor. But if you want to replicate, then everything I did, that's why I did not use an activator. That's not what I wanted to replicate. I didn't want to create those types of systems and problems. It's why I didn't do spinal decompression. It's why I didn't do orthotics. It's why I didn't do a lot of things, because it violated line of law extension, decreased my efficiencies, because I knew how to get and keep business. I knew how to get and keep back pain and neck pain, to do way more business than I physically can handle. And that was much more easily replicatable as far as bringing on associates, staff, much easier, much lower systems with staff to learn and keep up with, and training doctors and moving them out. So these are all the variables you want to consider. And the only thing I would say is, don't just randomly shoot off somewhere because your friend is. You're going to have these factors to consider: space, labor, more labor, or the existing labor, more time into that category, equipment, and then the actual system, as opposed to them going A, B, C, and D. Now they got to go A, B, C, D, E, F, G. Those are all the variables that most people are not even aware of every time they bring a new system in. So having said that, there are many other horizontal factors you can do with billing. Like I said, orthotics is a common one. TENS units are common ones. From a billing standpoint, TENS units pay real well. Orthotics generally pay real well. There's ways of bringing those in and acclimating them too. And then, like I said, if you wanted to actually bill for multiple areas of adjusting, like extremities, but you have to do those diagnoses, you got to do those workups, and in other words, they're all individualized from day one all the way through. And then also some common ones are home instructions. So these are some of the common factors that you might want to consider with your fees and your services and your billing. So let's take a look at some possible opportunities here. So patient comes in, let's just take the standard insurance patient. We've got the consultation, we do the examination. Is there a possibility for an extremity for treatment and billing? Yes, I'd say probably 35 to 40% of your business, you'll probably find that somebody has an extremity that you'll be able to evaluate, give a diagnosis, and do treatment and billing for those. That is common. Okay? So that is an opportunity. Okay? Now, how far off you go, that's the question, is how far off are you going to go? Because really we're talking about a replicatable machine. How the high efficiencies of a replicatable machine. That's really what's going to create you leverage of time, not short-term thinking with billing, and now you got a very difficult system to replicate, or it's not even replicatable. You'll be stuck in that office the rest of your life. So those are some factors with the examinations. Those are some of the factors with home therapies, given directions for home therapies. You can do billing for that. Give them directions for home exercise and therapies. That is an option. That's a very easy one, by the way. I'm going to tell you what I would suggest also. That's a really easy one to implement and make part of your system. That you have, and then there's the standards. The back pain and the neck pain. You don't have to have exercises and therapies for every joint in the body. So that's a common one that I would consider, is making sure that you give directions for home instructions and billing accordingly for that. A lot of you are probably doing that anyway. You just may not even be aware that you can bill for it, or how to bill for that. The other factor that I would look at is orthotics. I would consider that. Now, I would a lot of the insurance companies will pay for orthotics. That is a higher dollar compensation. Now, the only thing I would advise against is, I had one doctor I consulted with, and he was just so intent on getting an orthotic fee out of that patient. So the patient would come in with low back pain, and they would even he would not even get around to talking about the low back pain. He covered 5 other topics before he finally got to their chief complaint. He's checking the arches on their feet, something they didn't even come in for, before he even talked about their low back pain. I just could not believe what he was doing. So that does not mean I don't recommend it. I would, as part of the structural evaluation, I would analyze their feet and check for orthotics, and as part of the insurance, verify that what coverage they do or don't have. Let's face it, if they're paying insurance for it, that's what they're paying for. So if they have the problem, as part of the evaluation, I would document it, and I would have a very simple orthotic procedure. Now it's so simple nowadays with the digital scans. Those are just very easy. But orthotics are very profitable. Any of you guys do orthotics? Okay. I would definitely look into orthotics. Now, if I had to compare orthotics to home instructions, I'm not going to, I might only bill, $25, $35, $45 for home instructions. Orthotics will be $300, $400, $600. Okay. So from a unit of time cost analysis, it's a very worthwhile procedure to be evaluating and looking into. Now, what else are we looking at with the exam? We talked about the different degrees of exams. We talked about the different anatomy with the exam. One thing that I would consider, if I were you, is one extremity. Remember, I told you about 40% of the patients come in with one extremity problem. Now, a lot of times you're working it up anyway, but you're not working it up separately, and you're not billing for it separately. So I would, if I were you, consider looking at the extremity in consideration. Remember, everything I'm talking about is valid. We're not talking about making anything up. So I would, in the consultation, be looking at the extremity, seeing if they're having a related extremity problem, and giving the diagnosis for that extremity and the appropriate adjustment for that therapy, for that extremity, as well as appropriate therapy for that area. I would consider that. I would definitely look at one extremity in the evaluation. It's part, and remember, all of this is contiguous. It's not like we're talking about detox or, something totally unrelated to what the reason they're there for. It's totally contiguous with the reason they're there. And most of the time, you're going to be evaluating this to some degree anyway. Chances are you're going to be evaluating, their posture, how they're standing, or with their orthopedic test. Somewhere you're going to be seeing something more in orthotics, in the orthopedic test, something. Somewhere you're going to see something with extremities if you did muscle testing, range of motion, and palpation. So all I'm suggesting is you're probably already doing, over half of what needs to be done if you're just aware of it, and then just include it in your consultation, exam, diagnosis, and part of your protocol. But remember, you have to have the workup. You have to have the consultation for it. You have to have the diagnosis for it. You have to have the SOAP notes for it. You have to have everything for that diagnosis, just like if you did with back pain. So it's a parallel. So it does add more work, but it gets pretty easy because it's what you're doing anyway. So that would be some major factors. TENS units are paid real well also. I would consider TENS units. Is any of you guys doing TENS units? Okay. So I would consider doing TENS units also. It's not that far off. It's kind of in line with what you're doing. You're already probably doing a lot of, it's the same thing. You're kind of already doing a lot of the work. You're probably just not doing enough with the billing with it. So the TENS unit. I would definitely look at the TENS unit. I definitely would. Those TENS units, those are $600, $800. Okay? Those make big differences. By the way, just so you guys know, David, I think, has a $100 per visit collection. He's got one of the highest dollar per visit collections, probably, of anybody here. So that's a little bit about the definitely. And again, we're not talking about exceptional space, labor, and equipment or training as far as systems. It's all almost contiguous with what we're doing in patient flow anyway. They're just minor additions along the route. They're not like detox or, nutrition, way off, things that are just way off. So now when we go to, before we leave the exam, is any comments relative to the exam or supplements? Is anybody doing anything else that we have not talked about? Chris, are you doing anything else we haven't talked about on day one with the consultation or exam? Okay. David, are you doing anything else? Consultation or exam that we haven't talked about?
You said just on day one, correct?
Yeah, consultation, exam, treatment, day
No,
one.
that's it.
Yeah. Okay. Now, as from a therapeutic standpoint, there's the passive therapies. Now, one thing I definitely recommend is do not do the therapy in your office that you're not paid for. And that's one of the common ones is an ice pack. I mean, if you're not getting paid for ice pack, or if you can't, the insurance does not reimburse, stop doing the ice pack. Send them home. Do not be wasting your time, space, and labor. And, I was actually, a doctor was telling me that he actually did ice packs with the patient. I could not believe it. So he's occupying, so now he needs the equipment. He's got the labor to deal with it. And again, we're not talking one person here. This is a system. We're always thinking in terms of, is this a system? Will I be able to do this for 200 people a week? That's the method of thinking, not a one-off type of thing. That is not the way you think of your business because you have a model. So yeah, this doctor was occupying space on a table. He was occupying labor. He was occupying equipment, and I'm like, what are you doing? Well, why don't you do everything else free too? And of course he was able to justify it. It's amazing how we'll justify everything. So here he was trying to justify this. And so I said, well, why don't you go ahead and do this other activity that's not paid for either? And then add on top of that, that's good for the patient, because he did it from an ethical standpoint. Well, it's good for the patient, and I think that's what they need, and blah, blah, blah. Well, they can do it at home. And there's a lot of other stuff. If you want to be that ethical, there's a whole lot of other stuff you could be doing for the patient that cost you money that you can't pay for also, or you don't get paid for. So don't be doing any activity in your office that like that you don't get paid for. So if you don't get paid, and by the way, a common one is hot packs and ice packs. They have no business doing hot packs or ice packs in your office. They can easily be doing those at home if you don't get paid. Anybody here doing an ice pack that's not charging and getting paid for it? Okay, good. All right. So, and then there's the typical passive therapies, right? A little passive therapy on day one, a little passive therapy. Typically, whether it's ultrasound, pulsed ultrasound, muscle stim, things of that nature, intersegmental traction. A lot of times, from a clinical standpoint, I found intersegmental traction actually irritate the joints. I never put patients on intersegmental traction the first 4 days because I just personally found that it irritated them. And then from an active therapy standpoint, remember you can do passive therapies, active therapies with the patient. Typically, you wouldn't start doing an active therapy right away. But one active therapy that I'm really big on that's very easy is a modifier. It's a PNF modifier. And you could very easily start that on day one, but not necessarily. So typically on day one, it's the consultation exam, it's the x-rays, and a passive therapy. That's kind of typically like muscle stim, something like that. And then when we talk about the x-rays, it's the same thing. Be aware that, if you're taking all these x-rays for a personal injury case, but then all your cash patients, there's 2 x-rays. Just be aware that when your x-rays, I don't know if you guys know this, but everything you do is in a database. They already know what you're billing, the services you're billing, and the categories you're doing them in. They already know. And all they do is they look for aberrations. Are they seeing it? What's the aberration relative to you, that statistic? And then what's that aberration for within your industry, people in your town? What are they doing? That's all they're doing. When they see high aberrations, that's typically when you're going to get looked at, besides somebody within your facility raising their hand and saying, hey, something's not right here. But it's the aberrations in the numbers. That's what they look at. Are you fitting in with the actuarial norm? Are you the outside in that category? So the therapies typically, so when you look, the x-rays. So just be aware of that. Typically when I came in, I told you part of the protocol was AP lateral obliques and motion studies. And motion studies are dynamic studies. So they're telling me, a lot of times in the beginning, I'll do a motion study, just check for aberrant motion, but also if there's any ligament damage or restriction, things like that. But I always took motion studies in the beginning because, again, we're dynamic people. We're not static. And a lot of times the dynamic studies will accentuate things that you don't see. So that was a typical study. It was an AP lateral oblique and a flexion extension or left and right lateral bending in the low back. Unless there was, if there was other types of symptom signs, then I took the standard Davis series or something like that. But that's kind of the standard x-ray series that I would take. Again, it's better to take more x-rays than not enough to make sure you don't miss anything and you have that information. One of the things that I point out to new doctors now is some insurance companies don't pay for x-ray, or they don't pay very well. So one of the things I do with all my new doctors is I have them do a cost analysis. I have them go back to last month's, figure out all the different x-rays they would have taken for each of the patients, what those collections would have been relative to the fixed expenses of x-rays, with the cost of the lease in the machine and the cleaning if you have chemicals or whatever. And so I'll actually do an evaluation of a cost analysis. And sometimes in the inner city, a lot of times the insurance companies are contracting with the MRI centers and not even reimbursing the chiropractor. So a lot of the times in the inner cities, I'll just tell the chiropractor not even to get an x-ray machine, use the local MRI center, just because it's just not from a profit center, time, effort, efficiency, it's just not worth it. But you always want to look at it from a statistical standpoint first. So that kind of covers some of the basics with the first day with fees. Let's take a second here and just go into that a little bit. So Dave, you're doing orthotics, is that right?
We do some, but it's pretty rare.
It's pretty what?
Pretty rare. I'd say if I do maybe one or two a month.
Okay. Why is it rare?
It's I guess just not something that I bill for, and we've had issues with reimbursement in the past.
Okay. The first thing that I would do is check reimbursement, right? You don't want to start spending time and energy and money on something you're not getting paid for. So first I'm going to check reimbursement, right? That's the first thing I'm going to check. What's for the major insurance companies? What's the UCRs for the major insurance companies? That's easy to find out. One phone call can figure all that out to the insurance company. Now, I'm going to do an evaluation. I'm going to do a statistical evaluation. I'm going to go, okay, well, based on my last month's patients, and you could go back 6 months. It's always better to go back 6 than 1. And then all the different types of insurance companies. What kind of revenue would I have received if, say, only 25% of those people would have had orthotics? And then immediately I can evaluate whether it's a profit center or not, or a potential profit center. So one of the things I would do tomorrow, if you're not doing this, is have your staff call with the different insurance companies of your new patients that have come in. Just use the common insurance companies that you use. Have her call and check what the UCR is for orthotics. Okay? And then it'll give you an idea if it's something that you actually want to do. Now, it's real easy to implement because it's just part of the exam. When I'm doing their examination, I'm going to be, like, let's say it's low back, I'm going to be doing the complete range of motion and all that. Well, while I'm checking their range of motion and they're standing, I'm just going to look at their feet and I'm going to put my hands right down under their arches and see if they've dropped or not. So see if there's inversion, eversion, or, check the positioning of the feet. So real quick, while I have them standing, while I'm checking their range of motion, it's just that quick to reach down there and check their arches to see if they've dropped or if there's some structural problems there. If there are, then I'm going to do an evaluation, see if that insurance covers it. If the insurance covers it, that'll be part of the procedure is getting a set of orthotics. The only thing you want to be careful with is you want to be real careful of when you implement this stuff. Because like I said with that one doctor, I gave you the example. The person's coming in for low back pain and the doctor's not even talking or examining their low back until he's covered 5 other categories. So you want to make sure that it's in the proper order in its application of its evaluation and in its delivery. So as an example with orthotics, it's real easy to have see the situation in the exam, and then it's real easy to run a quick scan as part of your initial physical exam. It's just real easy to do that. And then all I'm doing is following up because I don't want to create confusion. Remember, you don't want to throw all kinds of stuff in here off the main focus point. I don't want to create confusion by bringing in all this other stuff. So typically, I will finish out that patient with what we're dealing with. And then the ancillary stuff will just kind of add right to that, whether it's orthotics or TENS or whatever. But I don't want to just jump everything in there and throw a TENS and orthotics and then create a tremendous amount of confusion right up front. That's when patients will be bolting left and right. So just a couple comments. What about TENS unit? Are you doing any TENS units, David?
Yes, we do.
Okay, and how do you do that?
For our company we use,
No, that wasn't, I didn't ask the question right. What's the procedure? When do you evaluate it? When do you determine if you're going to do it? When do you talk to the patient about it? Where in the flow?
Typically it's based off their history. If it's more than 30 days, so we bill a chronic code for to justify the 10 units. So if it's more than 30 days, that's when we start to either include or not include that patient for a 10 unit.
Okay. And
so the majority of our PIs will get them, and also some of our major medical, we have all of our UCRs figured out for 10 units.
Okay. And what kind of reimbursement fee is there for that?
Well, PI we're getting probably $750, and major medical we're like $450 to $500.
Okay. And then how are you introducing it? On day 1, day 2, day 3, what?
I guess depending on where we are in that 30-day process, but normally or day 4 or somewhere along a little bit further in the care, it's not something we typically jump on right off the gate.
Okay. I tell you what we'll do is we'll create a separate video on how to handle the orthotics and the TENS unit and placement and strategy and what you'd say and when you'd say it. What's the number one thing you want to be careful with any of this stuff? Number 1, changing the focus of where their priority is and putting that other stuff in front of it. That's when you will create confusion and lose the patient, or doing too much. That will create confusion. So you got to be real careful when you're introducing it, along the line, and always making sure the major stays the major. Whatever their major complaint is, that's what you're staying on as the major and reinforcing throughout as you introduce, doesn't matter if it's a TENS or it's an orthotic or whatever else it is you're going to do that's supportive. So just a couple. So we'll do a separate video series on, the introduction of an orthotics, evaluating it, as well as for the TENS unit.